Dear chairs, dear audience, it's a pleasure to see you here again at the 6-month progress report. Let me introduce to you my PhD topic. The title of my PhD is Correlations of Temporomandibular Disorders with Body Position and Posture. My name is Dorottya Német. I'm a physiotherapist and a first-year PhD student. I am working at Bajcsy Zsilinszky Hospital at Budapest. My vision is to improve diagnostic accuracy and quality of treatment for patients with temporomandibular disorders, and my mission is to explore physiotherapeutic interventions for the management of temporomandibular disorders in affected patients. I am working on 2 ongoing projects using the methodology of a systematic review and the meta-analysis for the first one, and the methodology of a randomized clinical trial for the second one. The title of my first project is Investigating the Prevalence Rate of Forward Head Posture among Patients with Temporomandibular Disorders. TMDs affect 2.7 billion people worldwide. There are many types of this condition, but the common in those are pain, joint clicking, and limited jaw movements, causing discomfort for affected patients and impacting quality of life. We distinguish predisposing, initiative, and maintaining factors, and as you can see, muscle tightness is presented in all. The reason for this is the anatomical background of the cervical area. The temporomandibular joint is connected with the cervical, spine, and the shoulders to muscles and ligaments. So we hypothesize that posture problems may influence the development of TMD. Forward head posture is when the head is leaning forward out of neutral alignment with the spine, causing muscle imbalance in this area. This condition is increased among students and office workers and projected to increase by 32.5% globally by 2050. At the end of the background, we can say that if our hypothesis is true, right now many patients sit only in dental chair when they should be seen by a physiotherapist too. So my aim is finding out if there's a correlation between TMD and FHP. Here you can see my clinical question. Is forward head posture more common in patients with temporomandibular disorders? The outcomes are the prevalence of FHP and cephalometric angles like the craniovertebra, the craniocervical angle, the cervical lordosis, and the CVT-OPT angle. My hypothesis is FHP is more common in patients with TMD, and the clinical implication of this project is more effective treatment outcomes and less suffering for patients affected with TMD. Here you can see the search key I used on the left. I have 2 domains, one for the TMD and the other one for posture problems. I was searching in 4 databases and I found 2,731 articles. After title and abstract and full text selection, 39 articles left, and during citation chasing, I found 2 more articles. So overall, we analyzed 41 articles. The outcome measures are odds ratio for the prevalence of FHP and mean differences for the cephalometric angles. After meeting with a statistician, 2 outcomes were ready to make figures, so let's see them. The first figure shows the odds for FHP among patients with TMD and healthy controls. Knowing this info, dentists can determine whether or not it is more indicated to send the patient to a physiotherapist instead of dental treatment, or at least in parallel with that. The results are measured as odds ratio with 95% confidence intervals. Overall, these 6 cross-sectional studies included more than 1,400 patients. The heterogeneity is very high, which can be caused by the different diagnostic methodology used in the different studies. The odds ratio is 2.65, meaning that the odds for the FHP is 2.65 times higher in patients with TMD than healthy controls, which is a clinically relevant result, as 1/3 of these patients had FHP. These results are statistically almost significant due to the Munoz article, where the odds ratio not reaches 1. The second figure shows the mean difference of CVA between patients with and without TMD. Measuring cephalometric angles can lead us to forward head posture, which can be visible, but the angle data gives a more accurate picture. The results are presented as mean difference with 95% confidence intervals. Overall, these 10 cross-sectional studies included nearly 670 patients. As you can see, the heterogeneity is also very high, which can be caused by the different diagnostic methodology in the different studies. The mean difference is minus 5.75, meaning that patients with TMD had an average CVA 5.75 degrees lower than those who lived without TMD, which is a clinically relevant result according to the literature. And in the cervical area, almost 6 degrees has an importance in practice, regarding that the range of motion in the lower cervical area is, in normal cases, maximum 16.4 degrees. A few words about my progress. I am analyzing the data for the other outcomes, and I am assessing the risk of bias. The title of my second project is comparing the effectiveness of online versus face-to-face physiotherapy of temporomandibular disorders. Dentists and physiotherapists have two options for treating these conditions: the splint therapy and physiotherapy. Right now, the gold standard is individual physiotherapy, which contains manual therapy and active exercises too. Regarding that not many of these professionals are an expert in this area, patients have to wait for months or even years to get their treatment. There are articles about the effectiveness of e-health and online platforms which are promising for the professionals, and patients can find many information about their condition, but professionals are responsible to provide reliable and safe information to these patients. In view of this situation, my aim is finding out if online or group physiotherapy are as efficient as individual physiotherapy. Here you can see my clinical question. We will compare the individual, the group, and the online physiotherapy, and the outcomes are pain using the visual analog scale, the results in DCTMD, and the pain-free mouth opening. My hypothesis is that group and online interventions are not inferior to individual treatment, and the clinical implication of this project is to improve the efficacy of treating patients with TMD. We will include patients with myalgia only using the DCTMD diagnostic methodology, and we will exclude all systemic rheumatic diseases, children, patients with trauma, or after jaw surgery. After meeting with an expert and considering that we didn't find any previous studies comparing these groups, this will be a pilot study with 30 patients in each group. I would like to end my presentation with a quote by Albert Szent-Györgyi: raising a good problem, asking a good question, that's half of the job. Thank you for your kind attention.
Thank you, Dorottya. It was a really nice presentation.
Thank you.
Regarding to your first project, I have a question that how, in the studies, how do they determine the diagnosis of TMD, and for the first plots, was there any heterogeneity or was there any effect of the results for it, or can you be more specific about it?
Thank you for your question. In the diagnostic methodology, the gold standard is the diagnostic criteria for temporomandibular disorders, known as DCTMD, which assesses both the physical and psychosocial aspects of TMD, and this is the most common in these days. And also the Hell-Chemo Index exists. It focuses on the clinical picture, and also the Fonseca Anamnestic Index, which is known as quick screening. And the main problem with the heterogeneity is that these different indexes use different nomination to the different TMDs. For example, the DCTMD uses the myogenous, arthrogenous, and mixed groups, but the Hell-Chemo Index names the TMDs as mild, moderate, and severe. So this is the reason for the heterogeneity.
Thank you.
Thank you.
I am wondering if there are any further questions.
In that case, I have one question. Were you able to exclude or see if there were any vertebral disorders in the patients included in the first project?
Sorry, I don't
in your
really
first
understand.
project,
yes,
when you are looking for how the TMD patients have this forward head posture, do the patients, are those patients excluded that have other vertebral problems?
Oh, I see. Yes, we should think about that, and considering that the existing diseases should be excluded, but these articles didn't mention this. So, I mean, they didn't mention that patients had, oh, I don't know the name, but any of these existing rheumatic diseases.
Or any other spinal disorders. And have they mentioned any gnotological disorders that could maybe affect the TMD? TMJ?
There were one of them which mentioned, but regarding that I'm not a dentist, then I didn't really focus on these details.